Welcome everyone to this Plunkett Centre webinar. My name's Xavier Simmons and I am Director of the Plunkett Centre for Ethics. We at the Plunkett Centre are a philosophical bioethics centre and a joint initiative of the Australian Catholic University and several participating partner organisations in the health sector, including St Vincent's Health Australia, Calvary Healthcare, Mercy Health and Cabrini. We at the Plunkett Centre host quarterly webinars covering topics related to clinical ethics, as well as the philosophy of medicine and philosophy of healthcare. Recently, we've hosted webinars on moral distress, as well as a webinar on dignity in healthcare. And indeed, our last session was on the bioethical legacy of Pope Francis. We've had a new Pope elected since then, and he's made one of his priorities artificial intelligence. So it's very timely that our next topic indeed is focusing on artificial intelligence in healthcare, the topic we're discussing today. Whether it be medical scribes, machine learning diagnostics, or predictive analytics to manage patient flow through a hospital, AI is having a very significant impact on the delivery of healthcare. Much of the discussion to date has been focused on how we might balance the benefit of AI tools in healthcare with appropriate regulation and oversight. In today's webinar, we're going to take a step back and look at how large language models work and some of the uses in healthcare of AI, as well as some very fundamental questions surrounding consent, responsibility, and transparency in the use of AI in healthcare. Our speakers today include Dr. Maria Kirichenenko, an emergency physician in Melbourne and a lecturer in philosophical bioethics at the Plunkett Centre, Dr. Steve Matthews, our senior research fellow, and also Mr. Adam Weslinoff, our project officer. Maria will be speaking first today and will present a case to stimulate and situate discussion for today's webinar. Thanks very much, Maria.
Thank you, Xavier, and thank you everyone for attending this webinar. So I want to start us off to set a very realistic scenario, which is already happening in some of our healthcare places. And I want to introduce you Maria, who is obstetric and gynecology registrar, who is on call in a very busy unit. And it is a Friday night. So, of course, there is a lot of demand. There is a lot of things happening. Maria meets Anna, who is a young woman who presents with a cluster of symptoms, including abdominal pain, and assessed by our registrar, Dr. Maria. And Maria is extremely busy, it's short-staffed, and she has too many tasks to do, so she uses AI Scribe to write her clinical notes to help her facilitate discussion and assessment of Anna. At the same time as Maria finished her notes, she realized she would like to order an ultrasound scan to rule out some pathologies which might account for Anna's symptoms. And at the same time, as a scan is ordered, we recognize, and Maria might not know that radiology department, which provides the service, is extremely short-staffed. And to mitigate some of the risks, they're using AI-driven program that helps to generate reports of the scans. However, Maria is not aware of that. When the report comes in very soon, to all our surprise, it tells us there is some kind of pathology there, but it doesn't specify what it is or what to do with that. So Maria, as a dutiful doctor, contacts the radiology department to try and clarify what exactly happening, what that scan means. However, she's told that while this report is generated by artificial intelligence program, the radiologist who specializes in those scans is not available currently, and the scan will be reviewed within 48 hours to clarify that report. Next slide, please. So this scenario is a reality, and it is reality with AI or without AI. And this scenario highlights two probably biggest tensions. We have a very complex healthcare system. We have very complex patients. And we have as a doctor's responsibility and responsibility to our patients to be a good providers, to make a diagnosis, to assess patient, to be compassionate, to listen to our patients. But at the same time, we have responsibility to a greater kind of space of healthcare. We have responsibility to our organization, for example, to keep our KPIs and move those patients through the system. And to no surprise, AI tools are really tempting tools to improve our productivity. It can help, for example, Maria to see the next patient much faster because she is not typing her notes, but rather AI scribe typing those. At the same time, it's very tempting to use those tools to mitigate some of the risks, such as short staffing in the hospital, because AI can actually read reports, and we know some of that is quite effective, and then radiologists can just conform. So it improves the workflow. So the question today, what we are posing is, we are not going to answer all the problems of AI or not problems of AI or kind of good things about AI in a healthcare. We are going to look into the tension, what those AI tools are, and Adam is going to talk about it shortly, as well as where our responsibility as a doctors and the healthcare lies within AI system, which Steve is going to talk to us about. And I'm going to hand over to Adam to continue. Thank you.
Thanks, Maria. So good afternoon, everyone. My name's Adam Wesselinov. As Xavier said, I'm the Plunkett Centre's project officer. And today I'm going to give you a really brief and kind of deflationary taste of two things: how large language models work and some initial forays into very current research about the way that they are working with some of the ethical issues that arise from that. And then, as Maria said, I'll hand over to Steve, who will lead you through some of the philosophical and ethical problems. So first of all, how do large language models actually work? Well, let's start by just asking a simple question. Almost everyone's used ChatGPT or knows someone who has, but what does the GPT in ChatGPT actually stand for? Well, it stands for three things: generative, in the sense that the model can generate new text based on an input from a user. So you put a prompt in and ChatGPT or another large language model gives you a response in natural language. The P stands for pre-trained. And what we mean by pre-trained is that the model, you input a huge amount of data into it, and whether that's something like the entirety of English language Wikipedia or an enormous body of electronic health records for patients or medical imaging data or what have you, the model pre-trains itself before the human user gets in and makes any alterations. So the model essentially decides what it finds important. Later training is what you call fine-tuning, and I'll bring that up in the second half of my brief presentation. And then we move on to the most important part, which is the T, the transformer model. And what a transformer model is a kind of what we call neural network architecture that uses a specific mechanism called an attention mechanism to assign statistical weights to individual data points in the large body of data in the data set. And this is the mechanism that a large language model uses to pre-train itself. Now, attention mechanisms and transformer architecture are relatively new. They emerged really in 2017 after some research done by Google's research labs and published in this paper at the top of the slide called "Attention is All You Need." And that's really what sparked off the latest boom cycle in AI, which previously had been kind of struggling with natural language processing. But the attention mechanism is really where it's all going today. So to use an example that is used pretty widely in the AI literature, if you take a simple sentence like "the cat sat on the mat because it was tired," like when a human being passes this sentence and tries to figure out what it means, we've got a whole variety of ways that we do that. We know something about the nature of cats. We know something about the nature of mats. We understand grammar and various semantic rules around language. And also we have experience with all of these things, and maybe we've seen this kind of construction before. So there's a sense in which we've got a shared conceptual framework with one another that makes language intelligible. But that's not how a large language model works. And so in order to figure out which word, is it cat, mat, or something else, the it refers to, the large language model essentially has to go through its body of data. And that might include every book ever published on cats, every book ever published on textiles, a whole bunch of photos of, carpets of cats. And then also it has to figure out which things are not cats on mats, like cats on tires, cats under mats, dogs on mats, and so on and so forth. And what it does is it basically takes each one of these individual data points and breaks it down into a token, a numerical token, which you can see in the bottom diagram here on the screen now. So it takes each individual word or each component part of an image and breaks it down, tokenizes it, and then relates every one of those tokens really to every other token in the data set. So this is kind of why we call it a neural network. If you imagine an enormous, very complicated network of relations between all of these individual tokens, that gives you some kind of idea about what the large language model is doing. And you can see here in these three diagrams on the screen this notion of really breaking down the thing into its smallest constituent parts is how an LLM really works. What the attention mechanism then does is it takes these tokens and vectorizes them, which basically means that it kind of embeds them into this spatialized network. So if you imagine something like a game of Battleship, where you've got, your little tokens on the game board and you've got A1, A2, A3. So imagine a vastly more complicated kind of spatialized network where each one of these vectors is assigned a place. And then other kinds of semantic information are also attached to those tokens. Stuff about the nature of queries, kinds of values that come with that particular token, and so on and so forth. And all of this is discovered by the attention mechanism itself, not by a human user explaining, this is a cat, this is a dog, this is a mat, and so on. So all of these kinds of information are then computed and converted into basically a set of probabilities, and the attention mechanism then weights them with an extra token, which is called a context vector. And that particular vector captures really the meaning in like a short summary and attaches it to the token, so that the large language model kind of knows what that token is about, or has figured something out about that token. And it does this in parallel with multiple heads of attention operating at once. So you can imagine the LLM is like a team of specialists, each working on a different part of a general problem. The final output you get out of the large language model is a concatenation of all of these different heads of attention. So it's a very kind of complicated thing, and obviously I'm simplifying it quite a lot. But really the important implications of this are three that I've listed on the screen. The first is that large language models deal fundamentally with tokens, with individual discrete pieces of information, and don't really understand things like types, categories, grammar, or all of those shared conceptual structures that we use to process language in conversation and dialogue with each other. So it's not a database. And in the medical field, you could imagine, for instance, that a large language model will not see a series of case notes or an electronic health record as belonging to a patient. It's just a series of data points broken down to their smallest constituent level. Following on from that, large language models don't strictly know anything, because even though in their outputs, which are written in natural language, they simulate knowing, they actually don't go beyond a kind of emergent knowledge. Namely, they cluster all of these tokens into groups around attention headings and weights that they themselves determine. So if they have any kind of knowledge, it's like an emergent knowledge that comes from just the sheer scale of processing the data. And third of all, because LLMs don't really know in any strict sense, they also, on one account of know-how, they don't really know how to do things. They don't have a kind of knack for things. And that's just because all knowledge in attention mechanisms is highly probabilistic, whereas something like practical reasoning, which is the kind of account of know-how that many of us here at the centre like, practical reasoning is really the working out of a kind of universal concept in relation to a particular case. So something like health as a concept worked out in relation to an individual patient. How can we restore this patient to health, or what's their own perception of their health? We need a shared framework or a universal concept to really figure out how to apply things in a particular case. And that's not what a large language model does. So long story short, there are two very different ways of getting from the it back to the cat. And when we look at this in the medical field, in the most recent medical literature, this problem becomes pretty apparent. So what you see on your screen now are two images of retinas, and a very recent study published in July 2025 tried to train ChatGPT-4, which until about 2 weeks ago was the most advanced model, on license-free open access images of retinas to try and diagnose diabetic retinopathy. The first challenge was to try and identify what the images were, and ChatGPT-4 identified them correctly in about 73.3% of cases, whereas specialist retina experts managed to get up to almost 90%, 87.7%. But what happened then was really interesting, which was that ChatGPT-4 diagnosed nearly 91% of all images as having mild to moderate retinopathy. Namely, because it's clustering all of these images together under certain headers, it just identified a really large number of false positives, because it can't really tell what it's looking at. It actually doesn't know what it's looking at in any strict sense. So when it came to actually have referable retinopathy diagnoses, the overall referability amongst the specialists was only at 66.6%, so 2/3 of all cases. But ChatGPT-4 referred 93.3% of all cases on. So the conclusion this study found was that because of its tendency to overcall disease, the utility of ChatGPT-4 as a screening tool is actually minimized. And this kind of thing is actually replicated in many other diagnostic studies. So we tend to hear a lot at the moment about how efficient large language models and machine learning tools are at diagnostics. And that's true to some great extent. But the first meta-analysis of diagnostic studies was also conducted this year. The researchers looked at diagnostic tasks published between June 2018 and June 2024, and they analysed 83 of these studies, finding that the diagnostic performance of large language models was only really sitting at around 52.1%. So it wasn't necessarily any better or worse than non-expert physicians. However, compared to expert physicians, it was significantly worse. And so the authors of this study really concluded that the expert physician still has a significant advantage over large language models. So what then about fine-tuning, which I mentioned before? So when you take what's called a foundation model or a general AI, a general large language model, and you give it medical specific data to chew on so that it can understand something that's more domain specific. Well, there are a number of these, some of which are listed on the left there, and they all have funny names like BioBert and Gatatron and things like that. And they come in a whole variety of different languages. And there's also things like AI medical scribe tools, which Maria mentioned before, Heidi being one very popular one. But a 2025 study that's just recently come out by the Department of Computer Science at Virginia Tech basically gave a big scoping study of all of the various medical LLMs and found really quite significant issues, both practically and ethically, with a number of domains, including truthfulness. Does it actually give us an accurate picture of what's being asked for, privacy, robustness against cyber attack, bias, explainability, and safety. And they flagged a number of other issues which they simply didn't have the space to go into. So while these tools are extremely powerful, and they really are, the current literature seems to be suggesting that there's quite a long way to go with them yet. And that's even true about performance. So a second study, which was published this year, found that yes, fine-tuning does make these large language models much better at medical tasks. However, there's a kind of limit point where simply giving them more and more and more medical information actually makes them decline in terms of performance compared to the general model. And this is true in many other cases with large language models, where the complexity of the task being asked for actually seems to decrease performance quite rapidly. And that's true even of things like small games and things. So just to move on and conclude with 3 examples regarding fine-tuning out of recent research. The first is the thing that's bound to keep hospital administrators up at night, namely data breaches and medical safety. So in one very recent study from Korea, Korean researchers gave a large language model a significant number of electronic health records with sensitive patient information in them, and then used what are called prompt-based attacks. So not hacking the computer, so to speak, but just putting prompts into the large language model that follow a certain syntax to try and get it to spit out something that it really shouldn't be giving the user. And what they found was that the success rate of these attacks was something like 21.8%. So 1 in 5 of all of these attacks succeeded and divulged information that was a breach of privacy. So yeah, if that doesn't cause hospital governance boards and things of that sort to lose sleep, I don't know what will. A second study from 2024 found that fine-tuned medical large language models, if they're not specifically fine-tuned to take safety considerations into account, will often comply with harmful medical requests. And that includes not only harmful diagnoses or treatment plans, but falsification of medical records, concealing errors or negligence, violating confidentiality, and so on. So these things are quite susceptible to malicious prompting and can be defeated in many circumstances. And in similar domains with high risk profiles like financial services, people are very acute to these kinds of issues and are recommending a very prudential approach to the adoption of LLMs as a consequence. And just to conclude, bias is one issue which appears almost everywhere in the contemporary literature about large language models in healthcare. People are very aware of it and identify it consistently as one of, if not the most important issue to them. Here are 2 recent studies about bias. The first is that biases can enter into large language models at multiple points. So the training data is obviously the main one. So if you're training your large language model or fine-tuning it on data that is already skewed either by gender, by race, or by a number of other sensitive characteristics, that can skew the kinds of outputs that it gives you. the incorporation of flawed heuristics, namely the example they gave was diagnostic rules that overlook atypical symptom presentation in certain groups, or deployment in contexts that amplify existing healthcare disparities. So in certain cases involving people of low socioeconomic status or its use in the developing world and so on. And one other study from 2022 found that many of the diagnostic studies, so 423 AI diagnostic studies in this one particular meta-analysis, really failed in certain respects against a very common diagnostic standard, the QUADAS-2 standard. So, for instance, in the domain of patient selection for the diagnostic studies of AI, over half included a high or unclear risk of bias in patient selection. So that study concluded that it was a poor reporting standard that acted as a barrier to clinical implementation. And that's also true in terms of the heterogeneity of the kinds of experiments that are being set up to test diagnoses. So much of the literature also calls for more rigorous and consistent benchmarking, which is one way that these technologies will improve. So just to conclude this extremely brief and cursory overlook, there's a lot of pressure being put on people in almost every industry at the moment to become an early adopter of AI. And obviously the promise of this technology is enormous and is already delivering enormous benefits and is ripe for further development. But the research as it stands now seems to suggest that there are still significant hurdles that need to be overcome before it can deliver a really consistent quality of care. And so as the authors of that diagnostic meta-analysis concluded, at present, a significantly higher accuracy of expert physicians compared to AI models overall emphasizes the irreplaceable value of human judgment and experience in medical decision making. So if I can leave you with that before I hand back to Xavier quickly, the know-how of the clinician really remains primary. So thank you very much.
Thanks very much, Adam. That was great. And I definitely agree with that final remark that we always want to make sure that there are human actors making the final decision in these matters. And that is a good segue, I think, into Steve Matthews' presentation, who's going to talk to us about some of the ethical questions arising from the technology that Adam's just been discussing. So I'll pass over to Steve now.
So I'm going to address some ethical questions that generative AI raises, specifically in clinical care. And the key guide question, I guess I'll just read this, is how should we navigate responsibility and consent in healthcare in cases where AI tools are embedded in frontline care and potentially hidden within institutional workflows? That's the general guide question. And I just want to say something about Maria's case and our approach. So it's basically to navigate this question that you see at the top there, the guide question. We're going to use Maria's case, that is to remind us the example of AI scribe, which is what we might think of as a visible AI, and a radiology tool, which is a potentially invisible AI to analyze epistemic transparency, and that just means what do we know medically and who knows it, and two, healthcare system opacity, that is, what information is potentially hidden in the system. Lastly, how does this analysis affect our capacity for ethical clarity in clinical contexts and within backroom institutional workflows? I want to begin prior to sort of addressing those questions directly with some background thoughts about all of this, which I think are really important. Our method is to use Maria's case, and it provides a kind of literary conceit, if you like, or a kind of a foil against which we can raise the relevant ethical issues. As such, it really stands in as a kind of representative case for implementing or for considering some of the core clinical ethical issues. Now, the other thing is, a second thing is, there's an ever-changing technology at stake here. Practical ethics, where technology is concerned, is an ever-present and ever-evolving discipline. It's never finished. We constantly must integrate into ethical practice new technologies as they arise, and we must never conclude that the work is done. So it's in the nature of practical ethics, partly in service to regulation and legal frameworks to be constantly taking on changes as they occur in the technological landscape. Now, in line with this point, our discussion really today reflects current AI capacity. And as Adam pointed out, it's sort of in its nascent form. It's not getting it all correct, that's for sure. So this means that our points are really historically provisional. For example, what should we say about clinical bedside manner and the human touch if AI robot technology advanced to the point where patients could not discern the difference between human healthcare workers and synthetic robot healthcare workers? Now, this may be, this is fairly science fiction-y, but it may be closer than we think, I think, especially in, say, elder care or perhaps dementia care contexts. Ethical evaluations then should respond to current practice, but not meekly, of course, because unethical practices must be corrected. Another example, current Gen AI confabulates, that is, it makes up stuff when there's a gap in its knowledge, given the limitations of its training data. I believe that should be disclosed to patients. But nevertheless, confabulation will be largely eliminated in the future. So again, those disclosures to the patient can then reflect this change. Second point here, Gen AI is still in its infancy. So as the facts about AI emerge and change, the ethical landscape must change accordingly. A key question is, can the ethical changes be assimilated to past practice? Or is Gen AI, for certain things, genuinely novel such that this requires writing new ethical codes? And by the way, a non-AI example, I think, of genuinely novel ethical practice might be CRISPR germline editing for non-therapeutic traits. But we can imagine an AI practice, for example, a fully autonomous AI triage system, which is making life and death decisions in time-pressured scenarios. That doesn't exist at the moment, but that would be a genuinely novel ethical issue that we will need to attend to. As I say, we'll get to some other examples later on, but I think there are some cases, maybe Maria's case of Scribe AI, where we can assimilate that tech to already existing ethical frameworks. That's a key question. Now, I want to make a point about dual use. Ethical considerations tend to focus on the harmful risks of Gen AI, as Adam pointed out, but it really shouldn't disguise the potential AI represents for great benefits, I think, especially the touted benefits through, for example, AI robotic surgery, which is already coming online, through efficiency gains, and the potential avoidance of healthcare professional burnout associated with overwork, such as tedious administrative paperwork that a well-developed AI can take care of. So there are some really genuinely exciting prospects that AI represents. So I mentioned this is a dual use dilemma because, technologies tend to have positives and negatives, and we need to get that balance right. And finally, just as a background point here, I should say that today's session really barely scratches the surface, again, as Adam pointed out. It's said that Gen AI provides a kind of a key new plank for the fourth industrial revolution, so-called 4IR, a revolution which integrates such new tech as robotics, synthetic biology, and the Internet of Things, but also now Gen AI. So we're really at the start on this, and the question is, are we on the ethical precipice? So let's get to Maria's case. I just want to give you sort of the structure of the case. There's two distinct AI insertion points for this clinical chain. AI Scribe, which is patient-facing, it's under Maria's control, and AI radiology reporting, which is system level, not transparent to Maria or to the patient. So AI Scribe is an accessory, as Maria pointed out, or an assistant, if you like. It assists with that process, whereas the radiology AI program replicates the functional role of a radiologist, and that distinction is crucial. AI is destined to become more autonomous also, as we mentioned before. We're not going to talk about fully autonomous AI today, but I think that first distinction that Maria made is pretty critical here. These distinctions are important for the ethical questions. Since more autonomy for the AI means less control for clinicians and hospital administrators. It's worth contrasting this with automatic systems in jet aircraft, for example, where pilots and systems form a kind of hybrid control system. Another good comparison might be autonomous driverless cars. Those comparisons, I think, are useful because they can inform the present inquiry for the sake of getting at the ethical issues. Maria's case raises at least 4 questions around the following. Informed consent. Does Maria fulfill this in her case? Does Anna properly consent in that scenario? Second, epistemic authority. Does the AI know the things it apparently knows with authority for consent purposes? Third question, responsibility attribution. Where does responsibility lie? There's 2 things here. There's the role responsibility, which Maria may or may not have to a full extent. And there's a second issue about wrong actions. Who's accountable if something goes wrong? We'll come to those in a sec. Finally, trust and transparency. How does disclosure of the use of AI affect patient trust? Okay, informed consent in the AI scribe. Clinician role in consent. The AI scribe automates medical documentation. It captures doctor-patient conversations. It transcribes them, and it produces clinical notes or summaries for the patient's record. So it reduces paperwork. That's good. And it frees up Maria to focus more on direct patient care. All this occurs in a patient-facing context. Maria is the AI operator, and she is largely accountable then for the fact that AI is being used and to a large extent oversees what is being recorded. Patient awareness and transparency. Anna, the patient, might assume the clinician, Maria, is taking notes and that Maria is interpreting the significance of them, Maria, that is. If Anna does not actively realise that AI is listening, this could breach ethical norms of transparency. Data privacy and trust. Yet if Anna does know that AI is listening, she may self-censor out of a concern for her privacy. Such self-censoring potentially alters Anna's disposition to be honest and forthright in her disclosures about how she is feeling. And this raises a discussion question, which I'll just sort of briefly mention before we move on. Let's take a step back here. As I said before, it's not all grim news with AI. Are we overreacting to the fact that it's AI and just for that reason thinking it's morally risky? Does the AI scribe really require specific patient consent here? Or is a business as usual approach using general consent to treatment sufficient? This comes back to our earlier background point about whether certain AI technologies do in fact raise genuinely novel ethical problems. Okay, accountability, consent, risk. Opacity and fragmentation. Maria does not know that the scam was reported by AI. This gap in her knowledge potentially undermines both clinical judgment and accountability. It does so because it raises a problem about her degree of justified belief on the reliability of the information that she is working with. Is there a consent chain failure here? No one has informed Anna that AI, not a radiologist, interpreted her scan. There appears to be no mechanism for opt-out or for Anna to present an objection. System level risk. The radiology department is outsourcing diagnostic authority to a system that cannot be cross-examined with a 48-hour delay in human verification, as Maria put it in her scenario. A mistake here, if discovered through, say, an FOI request, could expose the institution to liability. some discussion questions. Who holds the epistemic authority here? The AI, Maria, the radiologist, or some combination of those? And does informed consent need to be dynamic and shared across services when AI is involved downstream? Final one, is there a duty to disclose that the initial read is AI generated and may be revised later? Okay, regulatory and practical challenges. AI raises the problem of a professional guidelines conflict. Radiology's historical standards around consent, for example, for contrast or radiation, highlight how patchy current practices already are. So the addition of AI, I think, brings further variability to this. Is the introduction of AI at this moment in time a good chance to revise and streamline the relevant standards? So there might be another positive here of AI, that it gets us to re-look at some of our management practices. System versus clinician responsibility. If Maria is unaware of the AI's involvement, can she be held responsible for acting on an opaque report? Or should system design take precedence here? What if AI produces a false positive with downstream unnecessary treatment? Or what if AI produces a false negative with harms arising from non-treatment? Right, these two possibilities we need to think through. Discussion point, should health systems flag AI involvement prominently on reports so that clinicians know what they're acting upon? As Maria pointed out in her scenario, she doesn't know that initially. So perhaps a little bit more transparency at that point in the chain is important. Okay, ethical risks if consent is not sought. First of all, autonomy might be undermined. Anna is left unaware that decisions about her care are shaped by non-human actors. Now, there's this concept, autonomy competence. Autonomy competence is enabled only because we understand what is really happening to us, right? I can only be autonomous if I'm apprised of the facts. Now, this raises the general issue of patient autonomy when a patient has a false belief, right? So, for example, are Jehovah's Witness patients genuinely autonomous? Yes, we assume that they are. Are anti-vax adherents genuinely autonomous? Yes, we assume that they are. An AI program that confabulates a wrong answer places the patient in a similar situation, holding a false belief about their condition. My view is that this does compromise their autonomy, because autonomy is linked to competence, and the AI, in this case, has compromised that competence. Okay, so there's a set of questions there around competence and having the true answers to the situation and what AI is doing to that. It's a messy area, but I think we need to think about it. Accountability. Accountability in this case is diffused. If harm occurs, tracing responsibility will be murky. Maria, is she accountable? The radiology department, the hospital, the AI vendor? This comes back to an earlier point. An AI, like a driverless car, must design in ethical values to the technology at the start. So responsibility is distributed to the various actors here. This does make accountability attributions difficult for when things go wrong, but that difficulty makes it all the more important, I think, to get this aspect right, assigning the weights through that chain, getting the distribution of responsibility weights right for the various agents in that process. Finally, on this slide, erosion of trust. Repeated non-disclosure of AI usage, where its use is suspected, could lead to a generalized lack of trust in medical institutions. And I think that's something to keep an eye on as these systems deploy over the long haul. more about transparency there. Okay, refusal to consent. Here's a practical implication. What if Anna does not consent and refuses AI involvement? Is there a human fallback? If not, are we creating an inequitable system? Would Anna's refusal delay her care or increase costs? What is the ethical obligation to provide a human reviewed option if one exists? Okay, 4 important questions there. I think the take-home message to those questions really is that we must introduce AI in healthcare with diligence, care, and meticulous oversight. Here's a framing question in relation to this. What kind of patient refusal should be honoured? That's a general question, but I think it has pertinence very much so here. And what are the implications if we can't accommodate that? Okay, so that really concludes my content, but I thought it'd be nice. I know there's a very busy slide, but I thought it'd be nice to just bring it all together in the one slide. So I'll just read through this so that we don't have a discrepancy between what I'm saying and what's on the page here. AI tools then mediate both how information is gathered and interpreted, subtly shifting authority away from the doctor and patient towards an inaccessible system. Consent depends on trust in information. Patients consent partly because they believe the risk-related information is trustworthy and authoritative. Source disclosure is essential. If AI contributes to medical decision-making, its role as an information source, it seems, should be disclosed to fulfill the moral purpose of informed consent, right? Documentation and AI involvement. Consent forms and clinical conversations should specify when AI is part of the clinical reasoning or documentation process. Responsibility becomes distributed. AI use dilutes traditional lines of responsibility, potentially involving designers, vendors of AI systems and institutions, and that raises accountability challenges, as I mentioned, if something goes wrong. Relational trust is key to consent here. Consent is not just transactional, or it shouldn't be. It should be relational, grounded in ongoing human interactions in clinical care between healthcare workers and patients. Bottom line, AI can complement clinical care, but for doctor-patient relationships, to retain their ethical weight, patients should know when AI is involved and why, and they should still be able to trust professional medical people. The bonds of trust in the physician and their expertise underpin and ground genuine consent. Thanks for listening.
Thanks very much, Steve. That was a fantastic presentation, and I think a very good analysis of some of the ethical issues arising from Maria's case. And so I'm hoping we can get in quite a few questions in these remaining 15 or so minutes of this webinar. And I just had a question to start us off, but I would also just at this point invite our audience to submit questions through the Q&A chat function as part of this Teams meeting. And my initial question, Steve, is directed to you specifically. And I wonder if you think that a lot of the ethical responsibility for AI actually lies with those responsible for governance policies in health services, insofar as if you have a strong governance policy to regulate the use of AI, that should theoretically allow you to assess all the technologies being used in your services and to make a judgment about whether one should be used or not based on considerations related to safety, bias, accuracy, these kinds of issues that Adam raised. So maybe Adam may also have something to say on this, or Maria, but I thought that might be a good point to start.
Yeah, it's a terrific point, because when I mentioned distribution of responsibility, that raises straight away a problem of who's providing the oversight, who's providing the leadership, where does the buck stop? Now, of course, you know, you know, in a hospital environment where we have various committees contributing to governance, there is still a little bit of diffuseness in that in the way things are governed. Nevertheless, somebody has to call the shots and make decisions and be aware that that distribution of responsibility could go wrong. Could come to bite us when something goes wrong.
Great, thanks. Any comment from Adam or Maria, or we can move on to the next question?
Maria, you first, please.
I think it's an important point because for this particular situation, if Maria receives a report which is AI generated and she doesn't know that it was the case, it undermines her authority in the space of professional practice, and she has no guidelines to fall on to explain that to the patient. So I think it's quite important to have a governance and clear transparency about what tools we use, because that also will help Maria to decide the timing of the scan, maybe.
Well, look, just to add to what Maria and Steve have said, I mean, I won't pretend to know anything about governance policies really, but the thing that I've become really interested in is almost at the other end, which is, you know, how people can kind of self-regulate their relationship with these tools. And one of the things that seems to pop up over and over again in current literature, not just in the medical domain, but in every other domain, is that the use of AI tends to put a fair amount of distance between the person and the things that they're doing with it. So, you know, it almost naturally leads to you feeling like you're less responsible for your actions, may encourage certain kinds of behavior in accordance with that. And there was a very recent study that showed, even at the level of kind of cognitive load, that as you're using artificial intelligence tools, you're actually working less hard. So I think in terms of, you know, how you go ahead with policy, that's one question. But at the other end, clinicians and indeed anyone who uses AI really needs to get a bit of a grip on how the technology works, what effect it will have on them, and really see their use of it as an ethical problem or an ethical question in and of itself. So I think there's that opposite end where you're trying to grab the problem from the top and the bottom simultaneously.
Thanks very much, Adam. That sounds right to me. We've got a couple of questions from the audience. Just one interesting one from Nicola Brown. She asks, I did also wonder about situations where healthcare professionals may refuse to use AI tools when implemented by organizations. So I think the question is focused on partly what Steve raised, this issue of what if patients don't want to participate in the use of AI technologies. But what Steve, I wonder if a healthcare worker themselves doesn't want to use the technologies, how might we approach that?
This is a very thorny issue. Look, on the fly, all I can think of is that this would have to be grounded in a conscientious objection. So for someone to make that refusal, they would have to provide a reasonable justification for it under the circumstances. Now, I'm talking very generally. It would depend on the particular AI, wouldn't it? And some of the issues that we've raised about the remoteness of the AI and the lack of transparency would give healthcare workers pause. I mean, Maria in that scenario is left in the dark, and she is at the coalface making clinical judgments without having full or necessarily reliable information. So I think somebody who's refusing to do that, but I mean, look, contact your union, contact your Plunkett Centre ethicist, and you know, work through the issues. It can't just be a blanket blind refusal. There needs to be reasons presented, and then we go through that process.
And I would like to add to that, it also depends where we stand with AI in the healthcare system, because at the moment it's not endorsed and is not mandatory, and some of us might use AI scribes, some are not. But we are looking into the future, then AI may be becoming kind of a part of our protocol. And like with every protocol, it leaves some space for clinicians' autonomy to reject something, providing that within the law. And I echo Stephen's kind of on the flight threat about conscious objection. I do hope that that's not going to get to that.
We've just got a question from Megan Best from the University of Notre Dame, who asks, would privacy concerns be eased if the AI does not save the data, or is the ongoing educative function within the system mean that they remain? Does it mean that they remain? So, yeah, do you think that would make a difference if the data wasn't being saved, if it was being deleted after, I suppose, the benefit had been gained?
Sorry, Steve, you go.
Oh, just a quick one. I sat on a HREC committee at the university for many years, 6 years. It's interesting. Privacy worries, at least at the research ethics level, were very limited. The thing that came up most of all was risk of harm. Now, it'll be risk of harm that occurs because there's a privacy breach. I think AI shines a light on this question, but I'm actually a bit more relaxed about this. I think the important thing is security of storage of data, right? You'll find that once digitized information gets into the space, it's very hard to remove. Now we can delete it and we can make promises, but I think the security of the data is the critical thing here. And that's not necessarily just an AI problem. It's an existing problem. Sorry, Maria, go ahead.
No, absolutely. I was about to echo that, because we do put our data into the health records. They're all now electronic and stored, but we have inherited trust in the hospital system or government systems that the data is protected. AI scribes, for example, problem is that this data is outside healthcare providing space. It's a private owned organization, and we have no idea what they're doing with that data and where it goes. That's kind of one problem. And if we can alleviate that, that might endorse a little bit more use of AI. And second is, if we use AI as advisory tool, the question is how much we are trusting the advice. Can we unpack it? Can we reason with that? And like Adam mentioned, AI doesn't have at the moment this practical reasoning to explain us why.
Thanks very much. So I'm just going to read out a couple of comments from fellows at the Plunkett Centre. So first of all, from Stephen Parnas, who says that patients seem very comfortable in my experience when I say that AI is being used in my clinical work, but that I am interpreting every aspect of its input in scribing. It also enables me to spend more time focused on the patient and their loved ones rather than a keyboard. And I think that speaks to this whole idea of how ideally this technology, these sets of technology, are going to help us to spend more time with patients in healthcare, and that way, like, enhance rather than diminish humanism in healthcare. So that's a very helpful comment. And then from Natasha Michael, some of the best answers and results in medicine arises from human curiosity, the continuous questioning to season. My concern is AI will lessen natural curiosity that is needed in medicine. So that's an interesting question, which maybe the panel might want to tackle.
Yeah, Xavier, can I pick up on this one? Because I read a recent survey of American physicians that said that something like 80% of them who were surveyed were most interested in the application of AI for administration, and that Steve and Maria both kind of mentioned burnout and overwork as being one thing that AI might be able to alleviate. And look, the technology is not there yet. A lot of recent studies have shown that it really struggles to pass things like long case notes, especially when they're written in doctors' handwriting, which is something that AI does share with humans. But that's a direction that, you know, people want it to move in. But then on the other side of the coin, as you've mentioned, you know, medicine is also a humanistic practice, and the reflection on the case and the process almost of writing and reflecting on the patient's individual circumstances actually can help the person think through the case and become curious and come up with other options. So there's like a dual use problem here, as Steve said, even at the level of administration where there are clear benefits. So maybe we want it to eliminate some kinds of really drudgery kind of style admin work, but leave the more humanistic parts intact. And I think this is why the sense of prudential judgment about where it ought to be used really must be in the forefront, because it's like a case-by-case basis at this point. There's no one big silver bullet solution for absolutely everything.
Great. So we're getting towards the end of our session, and we've got a few questions. So I might just read a couple of questions out. So the first one is from Andrew Liu from St. Vincent's, who asks, other than accountability, responsibility, and trust, what is the difference in ethical implications between using AI and using other technologies? For example, we don't consent inform patients when using dictation software for letters, nor do we consent patients to upload their information to EMR or other systems. So I'm wondering, I suppose, based on this question, whether we're being a bit too hard on AI, whether we're raising the bar for some reason. And I wonder if the panel has any comment on that.
Yeah, just very quickly, and then I'll pass to the others on the panel. That's a very good question, and it came up in our presentations. There's a nice distinction that's made between AI as assisting on the one hand, as replicating practice on the other, and as autonomously working on the other. So where the AI, I think robotic surgery in Europe, there's some really strong advancements where the AI is almost fully autonomous, independent of the human oversight. Once we have that distinct three-way distinction in place, I think that the questioner is right. If it's merely assisting, I think if the AI is just assisting like AI Scribe, there's a real question about whether it's introduced any novel ethical questions. I don't think on the face of it that it does. Things get murkier when it's replicating, and there's human practices and clinical practices, and there's less oversight. So there's a kind of a continuum of human oversight, and the less human oversight we get, I think the more novel and interesting ethical problems we get.
So, I mean, maybe we might just go to a final question given time constraints. And this is from Mark Green from Calvary. So Mark asks, I wonder if the advent of AI invites us to look at practice more closely, in that we use many technologies to support care, and this fact in itself warrants disclosure. Are we currently as robust as we should be in making these disclosures? And he goes on, I think, to highlight that this is an opportunity to reflect on the doctor-patient relationship in our ethical analysis, recognizing that across the spectrum of health and aged care, multiple relationships come into play, and there is a community of people involved in care. So in other words, AI comes into a community of practice and possibly not just one clinical relationship. So it's a couple of questions there about disclosure, and then also I think the broader community that's being affected by these technologies.
It's a very interesting question, and I just probably very briefly mention, yes, we use a lot of technology, and our technology getting more advanced and better. We don't consent patient to using certain technology like lab, blood test, and maybe we mentioned very briefly about what CT scan means. But I think it comes down to the question is, what do we do if technology is better than human? And we have some strange discoveries, what we call incidental discoveries, and what do we do with that? Because essentially we will need to consent patient if we find additional something on their scan. What does that mean? Where do we go? And we need to risk stratify for each patient, and we don't do it yet in a robust way. We do it in retrospect, but we don't do it prospectively, and the patient might not choose to use technology, scan or something, if they may be not ready to deal with consequences. So it opens a lot of questions, I think. It's a very good observation.
Great. Well, we're at 1 p.m. So I would just like to take this opportunity to thank our speakers for fantastic presentations and also a great set of responses to the questions that we've just discussed. And I would also like to thank our audience for tuning in today. We'll be bringing at least one more webinar to you this year from the Plunkett Centre, so do stay tuned. But thanks again for joining us, and do stay in touch for further details on other Plunkett Centre events. Take care, everyone.